There it goes.
Okay, good. Yes. Well, my name is Jacob Safrani. I'm a surgeon, a weight loss surgeon, and I work here in Costa Rica with Medical Tours and Clínica Bíblica.
Maybe you can talk a little
Okay,
bit about
the surgery.
Yeah.
Okay, diabetes surgery has been in the area or in the healthcare system around a few years now. The American Diabetic Association joined with the ASMBS, that is the American Society for Metabolic and Bariatric Surgery. They got a consensus on where the patients could they have surgery or not for obese patients but for diabetes. Right now, the consensus says that patients should have 2 or more treatments for diabetes.
When you say 2 or more treatments, do you mean other than their medication?
The 2 treatments for diabetes, and should have HB1AC, that is the level of sugar that they have in the red blood cells, should be above 7.0, and also they shouldn't have more than 12 years of being diabetic. Some of the patients, by being longer in treatment, the pancreas doesn't produce insulin again, so they don't have the good results. American Diabetic Association and the ASB concurred that if you have more than 5 years of resolution of the diabetes, can be called a cure. So you need to have a patient who has this kind of surgery and you have more than 5 years without any treatment. It's called a cure for the patient. If the patient decreases treatment, for example, a patient who takes insulin 3 times a day and takes 2 kinds of insulin and have any treatment that is orally medicated, and reduce the medication just to orally, it's considered a very good follow-up of the surgery. Even though it doesn't resolve 100%, it's being controlled more. So that means that this patient, even though it's still a diabetic, it's only take early medication, is going to have a lower risk of having complications of the diabetes. Because one of the things that diabetes does, even though you have them on treatment or you have it on control with medication, it have what we call organ targets, like for example the eyes, the kidneys, artery, the nerve, the heart, the brain, and it will produce complications in a short term and in a long term that are not reversible. So that means, for example, if you have a neuropathy because of diabetes, once you have that means the patient wouldn't reverse that even though they do the surgery, but it will stop progression of the neuropathy. That's one of the things that we like about the surgery for patients who are already with complications of the diabetes. What we want is for patients also to have a prevention of this kind of illness. That's why we are giving an option for the patient to do surgery and do a follow-up nutritional care after the surgery. Once we finish the surgery, for him to reduce the insulin and the medication that is given to any kind of patient. We have done it with obese patients. Now we've done it with thin patients, and with a very good success, almost above 85 to 90% of resolution of the diabetes the first few years, and that's very good success.
With the metabolic, the gastric bypass, what I've been told is that they can be off the medication immediately or almost immediately.
It depends on the patient. Mm-hmm. There are some patients, because what we're doing with the gastric bypass is making the pancreas that it was blocked with these hormones to start producing insulin. There are some pancreas that they actually produce insulin right away, and they can reduce really fast the first week and go without the hospital, discharge from the hospital with no medication at all. There are some patients, because of the stress of the surgery, can increase a little bit of hormones that inhibit insulin, but they will go less than the usual normal, and they will actually be lowering down the dosage every day, and they will see that the 8 to 10 days that they're gonna stay here in Costa Rica, that the medication is going to wear off, and so we'll take it off. So there are two kinds of follow-up on the patient. There are some of them the next day, and there are some of them that it will take a couple of weeks just because of the inflammatory process of the surgery.
And I was told that there are two procedures that you're offering. One is for obese patients, one is for people that are not obese,
Yes.
for the diabetic improvement.
Usually,
Is there a difference, a much of a difference, and is there less complications with either?
Usually, the complications percent is really low. We have less than 1% of complication in either one of them, because those are patients who's going to prepare for surgery in a nutritional way. So they're going to come here really prepared. And also, when we do this kind of surgery, we change a little bit the modifications. For example, the gastric pouch in a patient who is obese is smaller than a patient who is non-obese, because we don't want him to lose weight as much as the metabolic part of the surgery. So it's different surgeries, the same technique, but different limitation or specification on the gastric pouch, on the length of the alimentary limb or the biliary limb. So it depends. But overall, it's the same surgery, just modified.
One of the things that I get is people ask me side effects. What do you see as side effects, and anything that you would say is restrictive or someone should be aware of, or are there side effects, the amount of side effects, the percentage that could be traumatic for
Okay. Well, after every kind of this surgery, metabolic surgery, they have to go into what we call a post-op diet that it takes about 5 weeks. And then after that, they start trying all the food that they can have with healthy standards. And then after that, they need to take vitamins at least for the first 3 to 4 years. What kind of vitamins? Any multivitamins that they can get. At the first month, they should be chewable because they cannot swallow pills. And then the second month and forward, they can do any kind of pills that they want. They can get it anywhere. They can get it at Walmart, Target, GNC, Vitamin World, whatever they want, whatever they like. What I also tell the patients to do follow-up appointment with primary care physicians. At least twice a year to see how the iron levels are, vitamin B12 are, and all these things. But you're changing a treatment of diabetes for taking vitamins every day. So I think that's a fair treatment that you can do, or treaty that you can do with a patient.
A fair trade-off.
A trade-off, yeah.
Have you seen problems with what they call dumping?
Yes, the dumping syndrome is usually less than 8% on the patients. But dumping syndrome is just a reaction to the quality of the meal that they could have. For example, if they eat a lot of saturated carbs, that could increase dumping syndrome. So what we do with a patient who has some dumping syndrome is we see the quality of the meal that they're eating, and we give him recommendations on what to eat to avoid dumping syndrome. Dumping syndrome is just a reaction. So if you don't eat that kind of meals or that quality of meal, you're not going to have it. But this is something that could happen with the patient. But
And
it's not
basically what they're eating, not a complication of the surgery.
Exactly.
And, do you feel that the medications that are offered for diabetes, insulin and all the other types of insulins, actually can do as much or more harm long term than the actual diabetes, because they're very difficult for the body to absorb?
Yes, usually the treatment, when you see when insurance see or FDA sees this kind of treatment for patients, what they want to see is the treatment of surgery is effective. Yes, it's effective because ADA approved it, and actually the FDA and all the